Today I am going to discuss few points on managing gestational diabetes, controversy to consensus. I could stop my lecture by saying one word that there is no now controversy and everything is consensus. But as I am giving 20 minutes time, I will try to discuss some old controversies and what are the consensus we are maintaining with the help of the DIPSI and the government of West Bengal. Most important and wanted guest is fetus in uterus. Pregnancy determines immediate fetal outcome, future physiology and pathology of both mother and baby, particularly future diabetes in both. Maternal hyperglycemia impairs fetal beta cell growth, loss of beta cell growth, loss of first phase of insulin secretion is more in gestational diabetes than in pre-gestational. Effective control in 2021 we can claim can solve the problem and help a lady to have a safe child and safe delivery. When I were medical students in 1960s, majority of the women with diabetes were not allowed to become pregnant because there will be problem. Now in 2021 with newer insulin, newer blood sugar machines, and also the ultrasonography and other assistances and our developed knowledge, we can promise most, if not every lady pregnant with diabetes to have a safe delivery. Few points on the pathogenesis of gestational diabetes. In normal pregnancy, there is increased insulin resistance due to the hormone released from the pregnancy, and there is counteracted by excess insulin hormone, so the blood glucose is balanced. But in gestational diabetes and pre-gestational diabetes, the insulin secretion falls back and there is hyperglycemia and multiple problems in cases of pregnancy. The maternal complications are hypoglycemia, diabetic ketoacidosis, retinopathy, nephropathy, hypertension, diabetic gastropathy, preterm birth, premature rupture of membrane, development of type 2 diabetes, hypertension, coronary artery disease, dyslipidemia, and obesity in the mother. For the fetus, first trimester, malformation, growth retardation, fetal wastage. Second trimester, hypertrophic cardiomyopathy, polyhydramnios, erythemia, placental insufficiency, preeclampsia, fetal loss, and also loss of IQ in the future. Third trimester damage, hypoglycemia, hypocalcemia, hyperalbuminemia, respiratory distress syndrome, hypomagnesemia, and intrauterine death. Long-term consequences, type 2 diabetes develops in 50 to 70% of GDM mother if followed up to 20 years. Children born to mothers with GDM are at an increased risk of childhood obesity and early onset type 2 diabetes. Moreover, female offspring of mother with GDM, when will pregnant, we again develop the GDM and the vicious circle will go on from mother to female child and there will be explosion of diabetes epidemic. So it is told, if you want to control the epidemic of diabetes, best treat at the level of the GDM. The GDM management consists of the assessment of the case, glucose monitoring, medical nutrition therapy, lifestyle management, oral agent, insulin, obstetric care, and follow-up. Diagnostic criteria, there are many diagnostic criteria. O'Sullivan, 1965, NDDG, older one, Carpenter-Causter, more older, ADA recently revised, and DIPSI, there is also WHO criteria. But I can tell you, don't jumble your brain with so many criteria. Just keep it in mind, only the DIPSI criteria, which is approved by the government of India and is the only legally accepted criteria for diagnosis pregnancy diabetes. And they say you only do 1-2 hour postprandial blood sugar after 75 grams of glucose, regardless of meal. I meal, patient may be on empty stomach if possible. If not, then allow her to do the blood sugar even at fed state, because you will have to think of the vast rural areas where patients cannot come properly in empty stomach, and moreover, not in India, but even Mose had mentioned that even in Israel, women are not allowed to go outside home on empty stomach. A single test procedure to diagnose gestational diabetes in the antenatal clinic, a pregnant woman after undergoing preliminary clinical examination, given a 75 gram of glucose load, Venous sample is collected 2 hours after for estimating plasma glucose by the GOD-POD method. GDM is diagnosed if 2-hour plasma glucose is 140 or above. That means above up to 139 is normal. If 75 gram glucose is not available, remove 5 teaspoonful of glucose from a 100 gram of packet. It will make 75. What are the advantage? Pregnant women need not be fasting. Causes least disturbance in a pregnant woman's routine activity, serves as both screening and diagnostic procedure. In the COVID time, this gave the excellent results because patients could not afford to go for multiple tests. ADA, they go for fasting 1 hour, 2 hour, 3 hour. These are not possible, not only for the problems with the patient, but also the hospital authorities, management, and the laboratory for multiple testing. All the diagnostic criteria require women to be in fasting, but most of the time pregnant women do not come in the fasting state. Attending the first prenatal visit in the fasting state is impractical in many cities, and the dropout rate is very high. A1C level, it was earlier told that they are not dependable, but it has been settled. A1C level during normal pregnancy is round about 6. And the best effect which A1C estimation gives us to differentiate a case between pre-gestational and gestational diabetes in the first trimester. If first trimester blood sugar is high, you cannot predict whether it is a GDM or pre-GDM. But if A1C is high, you can tell that it is existing near 3 months. So probably this is pre-gestational diabetes. Self-glucose monitoring, blood glucose monitoring is a very essential tool, has imparted enough success for achieving an ideal treatment. It should be considered the standard of care for pregnancy monitoring for everyone. Individual is the frequency and timing of home glucose monitoring. Those who are only nutritional control or lifestyle modification, they do not require daily multiple doses. But for those who are insulin requiring, who are type 1, who are very unstable, they require 7 tests per day. But on an average, a finger prick capillary blood glucose upon awakening in the morning or fasting sample 2 hours after breakfast, lunch, and dinner. Daily if possible, and if you cannot afford to do daily, at least at a gap of 3 days, is very much helpful for determining the glycemic control of the patient. The 2021 ADA guideline, they say fasting and postprandial self-monitoring blood glucose recommended in both GDM and PGDM. Fast glucose targets are fasting plasma glucose 95 and either 1 hour as 140 or 2 hour postprandial as 120 milligram should be the goal. Due to increased RBC turnover, A1C slightly lower in normal pregnancy, and ideally the A1C target should be kept below 6 if possible without inducing hypo. Where by attempting to bring down the A1C below 6, you are getting more hypos, then you keep between 6 to 7. Other tests, first trimester, I mentioned about the A1C, you must have a lipid profile, particularly triglyceride is highly raised, creatinine, thyroid function test, spot urine ACR. Second trimester, repeat ACR, repeat A1C, and capillary blood sugar as mentioned. Different other tests, if preeclampsia is suggested, 24-hour urine collection, blood urea nitrogen and creatinine, liver function test, uric acid, CBC count with platelet. You know that hyperuricemia is a marker for preeclampsia, and assessment of fetal well-being by non-stress test, amniotic fluid index, fetal growth and Doppler in selected cases. Imaging studies, first trimester must have a sonogram for dating and viability. Consider nuchal translucency if high risk for cardiac defects and also spinal bifida. Second trimester, detailed anatomy sonogram, ultrasonography at 18 to 20 weeks, and fetal echocardiography must between 18 to 22 weeks. And you also repeat in the third trimester the growth scan, and at the end to decide whether you will go for delivery or not. Other tests, long-standing diabetes, where you are suspecting a problem, you can go for ECG echo, regular screening for ophthalmic and renal disorders, and blood pressure should be assessed during each attendance. Aim to maternal plasma glucose values as to that of non-diabetic pregnancy. Fasting between 80 to 90. 2 hour postprandial between 110 to 120. And mean plasma glucose between 95 to 105. And most importantly, must have a birth weight between 2.5 and 3.5. In India, above 3.5 is macrosomia. Medical nutrition therapy, what is the goal? Adequate nutrition for the mother and the fetus, sufficient calorie for appropriate maternal weight gain, maintain normoglycemia and avoid ketosis. Composition, 1 serving of fruit and 1/4 of thali should contain cereals, 1/4 should contain protein rich, and 1 serving of dairy product. Half portion of thali should contain vegetable cooked as well as in form of salads. And the different drugs oral which have been used are recommended are metformin and glyburide. Gradually, we are receding from the use of glyburide because this comparison shows metformin good for glycemic control, glyburide, insulin both, but glyburide induces high maternal weight gain, increased risk of neonatal hypo, high neonatal birth weight and macrosomia, and insulin is also associated with high maternal weight gain. There is no significant difference in maternal fasting blood glucose or A1C level in patients treated with insulin, metformin, and glyburide. However, glyburide treatment is associated with increased risk of neonatal hypo, high maternal weight gain, high neonatal birth weight, and macrosomia. So we are avoiding this. We are using metformin and insulin. And this is a study, Indian study, where metformin versus insulin has been compared. And metformin is an effective and cheap treatment option for women with gestational diabetes with or without supplemental insulin. But our government of India has allowed the use of metformin for the second trimester only. Metformin versus insulin for the treatment of gestational diabetes in 2007. Rowan was the first person who came up with the first study, the mixed study, that gestational diabetes, metformin alone or with insulin is not associated with increased perinatal complication as compared with insulin. Also, women preferred metformin to insulin treatment. And in the mixed tofu study, that is the follow-up of the same group, after 7 years of birth of the neonate, they did not show much abnormality, little truncal obesity. But unfortunately, from this year, ADA is not advising for metformin. We believe India has got maximum degree of insulin resistance because of central obesity. And till now, our government of India has allowed the use of metformin. So I think metformin can be used from the second trimester with or without insulin. And WHO is of the opinion where you cannot give insulin at all, give something, then nothing. And in those cases, of course, metformin where you cannot use insulin for any problem. Insulin in pregnancy pros and cons. GDM who fails to respond to meal plan for 2 weeks. That means gestational diabetes, you start insulin after 2 weeks of lifestyle modification. If fasting is more than 90, 2 or more than 120, you will have to start insulin. If only fasting is high, you start with basal insulin. Only basal insulin approved in pregnancy is determined. If fasting is normal and postprandial is high, you start with short-acting insulin, of which fastest acting insulin piece of choice. If 3 postprandial sugars are high, give 3 doses before each meal. Fias should be used 5 minutes before. If say after lunch is only high, give before lunch only. But for pre-gestational diabetes, that means where postprandial is more than 199, you start insulin from the very beginning. The advantage of the fast-acting aspart, not I am discussing about aspart, fast-acting aspart known as Fias is that it start action within the 5 to 10 minutes. It reaches the peak before 1 hour, and it also reaches the plateau much earlier, so that compared to aspart, this is fastest acting. And I told the GDM is a disorder of loss of first phase of insulin. So nicely replaces the first phase of insulin, and subsequent recommend in the phase post phases, second phases are less, and control is excellent. Postprandial hyperglycemia is more predictive of adverse neonatal hypo than fasting outcome, than fasting glycemia. And rapid-acting analogs at present, 4 are available. I just discussed about the Fias, Aspart, Lispo, and glulysin. There is no data with glulysin. There is some fetal abnormality or growth regarding the Lispo. Safest is Fias, and next is the Aspart. And this is about the, again, comparison between rapid-acting insulin analog and regular human insulin. I use human insulin when the patient cannot afford. Fias is little costlier, but all advantages are with the Fias. Action begins faster, peak is higher, disappears faster. Neonatal hypo is inversely related to maternal hyperglycemia at delivery. So if blood sugar is properly controlled in the mother, after delivery, hypo in the neonate are much less. Aspart significantly reduces the death rate of major, total, and nocturnal hypoglycemia in the mother. When one cannot use a single insulin, or we are not using 4 insulin, that is 3 bolus and 1 basal for some logistic reason, we can go for analog CMEs. And for this, combination of NPH and Aspart, known as Novomix, are much better for all purposes. Fasting hyperglycemia, which I just mentioned, is high. You go for basal insulin. Older data has shown that glargine had an elevated IGF-1 receptor activity, may have some mitogenic problem. Insulin detamide is safer in pregnancy with respect to development and progression of the pregnancy. And data has also shown, of course, clinical data, no increased risk with glargine in congenital anomalies. With glargine, no detectable insulin glargine in the human fetal circulate. Glargine therapy did not lead to an increase in the large infants or congenital anomalies. But for all the purposes, our government, DCGI, has not approved glargine in pregnancy. The question is raised only when a patient is nicely controlled on glargine and becomes pregnant. If you suddenly stop glargine, the patient may become hyperglycemic and there may be fetal damage in the early pregnancy. Probably in those cases, you will have to continue glargine. How to start the dose of insulin? Insulin requirement, this is in terms of the short acting, 0.7, 0.8, and 0.9 to 1 units per kilogram of pregnant weight in the first, second, and third trimester. But actually, we require much lower doses. So to be safe, start with lower doses. There is a transient drop in insulin required dose in the first trimester, probably because of nausea and vomiting. And after 36 weeks, insulin requirement falls. In between, if insulin requirement falls, you have to suspect of intrauterine death. I will go for 2 studies made by us. A comparative study of maternal events with tight glycemic control. What do you mean by tight? Fasting below 70 and 2 hour postprandial below 100. We did it in 176 cases, A1C below 6.5. It lowered the incidence of preterm labor, wound sepsis only. But in 64 cases of pre-gestational diabetes, no extra benefit was seen, but chances of hypo was higher. What is the effect on the tight control on fetal complication? Higher incidence of small for dead babies, congenital anomalies, and total complication in pre-gestational than GDM. Large for gestational age, less with average control than tight control, and there are other problems. So now we are of the opinion fasting should be kept around about 90, postprandial 100 into 120, not go for very tight control. Association with the amount of insulin requirement, mean terminal glucose and HbA1c level. Average insulin requirement in PGDM was nearly double in GDM. The quantitative requirement of insulin did not alter fetal outcome. Maternal complications were lower in GDM cases, lower fasting plasma glucose only, but in pre-gestational DM cases with lower fasting plasma glucose, postprandial A1C values were all important. And this study answers questions of the patient. They ask that I am taking so much insulin, whether there will be any problem or not. The study has clearly shown no problem related to the dose of the insulin. Intrapartum care, GDM positive women for delivery, universal institutional delivery should be promoted, not at home. GDM women on MNT with controlled blood sugar, you can go for normal delivery. With problem, you will have to go for with insulin, you will have to better go for a cesarean section, and for problems with cardiac disease or any other, it should be delivered in very sophisticated higher post centers. Immediate postpartum and newborn care, maternal care, counseling for postpartum family planning, counsel women for 6 weeks postpartum follow-up test, detailed examination of women before discharge. Unfortunately, patients show all the interest during pregnancy. They need to be followed up by blood sugar estimation after 6 weeks, 6 months, then every 2 hours whether they are developing diabetes or not. That follow-up is very poor. Newborn care, initiate early breastfeeding, blood sugar monitoring of newborn GDM positive women within first hour of birth, and repeated 4 hourly up to 4 normal readings. So for every newborn, measure blood sugar from the heel peak by blood sugar small machine, and it should be below 45. Below 45 level as neonatal hypo. And the control is you will have to early go for teaching hypoglycemia for breastfeeding, and you start IV glucose. Don't give bolus glucose, continuous glucose, go on breastfeeding, and the baby will improve and measure. Post-delivery of follow-up of pregnant woman, test normal I have just discussed, you will have to do after 6 weeks, after 6 months, and then every 1 or 2 hours depending upon the situation. Now I am coming to discuss where is the controversy. We have settled all controversy regarding diabetes. Diagnosis, it is DIPSI guideline. Now we call it as a national guideline. These are only, I claim, legally approved guideline for diagnosing diabetes. 75 gram of glucose, 300 milliliter of water dissolved, give to a pregnant woman as early as possible. Definitely in the first trimester. We don't follow ADA criteria because our GDM criteria is much higher. Diagnosis and Professor Sesai has shown 44% are done in first trimester diagnosed. If we follow the ADA guideline, they do in the second trimester, we'll miss all this 44% and land up with complication. So no controversy diagnosis, single test, oral anti-diabetic, Metformin for our country only. Insulin, best is Fias and Detamine. If patient cannot afford, then you can go for the conventional human insulin. Follow up, no controversy. 70% patients of the GDM followed up to 20 weeks will develop diabetes, so require follow up. Unfortunately, doctors are not advising and patients are not also following. But what about the controversy? What is the problem? That is with the knowledge of the doctors. I'm very sorry to say, I apologize. The knowledge about the diagnostic criteria, treatment criteria, they all play games like examination of an elephant with a blind animal, and their attitude and also their practices are very slow. My experience with apology, consulting a diabetologist is not routine. Some diabetologists are high nose about DIPSI criteria. They always incline towards the ADA criteria. Majority of pregnant women don't have any blood glucose testing in our part of the country. 30 lakhs of women are becoming pregnant every year. 17 to 80%, that means 5 to 6 lakhs are diabetic. Good number of healthcare professionals do not know the details of the diagnostic value, target value, importance of self-monitoring. They do not advise, and best insulin and how to titrate insulin. Follow-up after delivery, very poor. Pre-pregnancy, premarital counseling, rare. Polycystic ovary, obese ladies, women with strong family history of pregnancy should always be before pregnancy counseled for origin or development of or chances of GDM during their pregnancy. Patient compliance very good if properly motivated, but again up to the child, but not after. Polycystic ovarian patients are not properly counseled that they are the potential risk for PCOS. And the result is, after so much discussed, so much thought of, so much invented, we come across with ladies with this who have lost their child. In conclusion, I like to mention all pregnancies are precious and diabetic pregnancies even more precious because we cannot take multiple chances for diabetes. Abnormality of glucose tolerance is detrimental to the health of both mother and her offspring. Due to the direct linkage between the maternal glycemic control and fetal morbidity and mortality, treatment of diabetes in pregnant women becomes further more crucial. Early detection of diabetes is a key to favorable outcome. Now some biomarkers are coming. And that biomarkers even take before pregnancy that you will have GDM. Any abnormality of glucose tolerance has to be managed aggressively for better maternal perinatal outcome and development of future diabetes in the society. The development of insulin analogs have made the achievement of maternal normoglycemia more attainable and has increased the convenience of insulin therapy. Compared to routine regular human insulin, aspart or FIAS has shown better outcome in diabetic pregnancy. These, along with simpler and convenient modern insulin delivery devices like pens, has revolutionized therapy in GDM. Most importantly, there is greater acceptance and compliance is adhering to therapy, resulting in a better fetal outcome. So I just recollect the advices of my guru, Professor V. Sesaya, and I call it as the doctor's Dipsi Mantra, or Samiji Mantra, after the name of Viraj Sami Sesaya. Screening for all in 3 trimesters. In our country, we should screen for all. 2-hour postprandial blood sugar after 75 grams of glucose regardless of meal. Postprandial 2-hour more than 109, it is PGDM. If 139 to 199, gestational diabetes. Target of treatment, fasting below 92 hours, below 120. Ideally, treat diabetes before planning pregnancy. For GDM, you treat with lifestyle modification for 2 weeks. If in the 2nd or 3rd trimester, you can try with metformin or combine with insulin or can go for insulin as necessary. Follow-up is mandatory. And I just dedicate my lecture and acknowledge that stimulus and the knowledge which has been given by all these ladies with their successful child. And I'm very glad that they are laughing with a successful theory. But these are not always happening. We'll have to increase the knowledge, attitude, and practice of the teaching doctor. Thank you for your patient hearing.